Welcome. Today, we're going to go way beyond just diagnosing an acute coronary syndrome. We're moving into the high-stakes world of precision lesion localization, taking a really deep dive into coronary anatomy from a cardiologist's perspective.
You've probably heard this classic saying in cardiology, right? The ECG is a poor man's angio. Well, that is our guiding principle for this entire discussion. You're about to see how the electrocardiogram, when you interpret it with a deep understanding of coronary anatomy, can reveal an incredible amount of detail about what's happening inside those arteries, rivaling much more invasive procedures.
So our primary mission here isn't just about making the diagnosis of a myocardial infarction. No, the objective is much more advanced. It's about identifying the precise anatomical site of the coronary occlusion. And listen, this isn't just some academic exercise. This has profound implications for prognosis and for management.
Okay, so let's dive in. We have to start by establishing the fundamental anatomical correlations. We need to build a mental map that connects the heart's three-dimensional surfaces to that two-dimensional view we get from a standard 12-lead ECG. This is our foundation.
And this slide right here, this is basically our map. The anterior or sternocostal surface is mostly the right ventricle, and you're going to see that reflected in the anterior precordial leads. Now the inferior or diaphragmatic surface, that's made of both the right and left ventricles, and it's visualized directly by the inferior leads, I, 3, and AVF. The posterior surface, mainly the left atrium, well, it's not really well represented on a standard 12 lead, which is why we sometimes need augmented posterior leads like V7, V8, and V9 to really see it.
All right, with that map in mind, let's switch gears to the right coronary circulation. We're not just looking at some textbook anatomy here. We're examining its structure from a cardiologist's perspective, really focusing on the functional implications of its branching pattern.
Now, before we even start to trace the path of the RCA, we absolutely have to lock down the concept of coronary dominance. This is all determined by which artery gives rise to the posterior descending artery, or PDA. In about 85% of people, the circulation is right dominant, meaning that PDA comes right off the RCA, and that's what dictates which circulation is responsible for the inferior and posterior walls of the heart.
This slide just lays it out beautifully, the functional anatomy. We can literally trace the RCA's path. First up, the SA nodal artery branches off, meaning a proximal occlusion can cause sinus node dysfunction. Next, the atrial branches, so proximal lesions can also kick off atrial arrhythmias. The third branch, and this one is absolutely critical, is the acute marginal artery, which supplies the RV free wall. After that, the RCA gives off the AV nodal artery, hello, potential AV blocks, and finally, it terminates as the PDA and the posterior basal branch. Every single branch point is a potential lesion site with its own distinct clinical consequences.
Okay, we've got the anatomy down. Now for the fun part. Let's apply that precise anatomical knowledge to interpret the ECG. Our goal is to synthesize that anatomical map with the electrical signals to pinpoint the exact location of a lesion inside the right coronary artery.
So, picture this. You're looking at an ECG with ST segment elevation in the inferior leads, II3 and AVF. You've diagnosed an inferior wall MI. Great. But now the real work begins. The first, most critical question you have to ask is this. Is the culprit vessel the right coronary artery, or is it the left circumflex?
The answer is all about vector analysis, and you can see it by comparing the magnitude of ST elevation in leads I and 3. Because lead 3's vector is oriented more to the right, if you see a greater degree of ST elevation in lead 3 compared to lead 2, that points directly to the RCA as the culprit. On the flip side, if the ST elevation is greater in lead I, the vector is pointing leftward, and that implicates the LCX.
All right, so we've confidently identified the RCA as the culprit. We're not done yet. The next step is to figure out if the blockage is proximal or distal. And believe me, this distinction is not just academic, it carries major prognostic and therapeutic implications, especially when it comes to right ventricular involvement.
So the anatomical determining factor here, the landmark, is the origin of the acute marginal artery. An occlusion that happens before this branch is going to cut off blood flow to the right ventricular free wall, and that results in a right ventricular myocardial infarction, or RVMI. A distal occlusion, one that happens after this branch point, well, that spares the RV free wall. The presence or absence of an RVMI is the key.
Now, on a standard 12-lead ECG, there's a really powerful clue for an RVMI. The injury vector from the RV free wall is directed anteriorly and to the right towards lead V1.
So this tries to produce ST elevation in V1. But even if the powerful forces of the inferior MI pull it down, you'll see this discordant pattern. Either you get frank ST elevation in V1, or you get ST depression in V1 that is way less than the ST depression you see in V2. That discordance is the key clue suggesting an RVMI, and therefore a proximal RCA lesion.
Okay, we've covered the right side pretty thoroughly. Let's shift our focus over to the left coronary circulation. Specifically, we're going to dive into the workhorse of the left ventricle, the left anterior descending artery, the LAD. We'll use that same functional cardiologist-centric approach. So the LAD's major branches are the diagonals and the septals. For our purposes, we'll focus on 4 key branches in their typical order of origin. The first diagonal, or D1, supplying the high lateral wall, the first septal, or S1, supplying the interventricular septum, followed by the second and third diagonals. Knowing this sequence and the territory each branch supplies is absolutely essential for precise localization.
And this table just neatly summarizes that electroanatomic correlation. The high lateral wall supplied by the D1 branch, that's reflected in leads I and AVL. The septum, supplied by S1, you'll see that in V1 and V2. The big anterior wall, supplied by the main LAD trunk and its D2 branch, corresponds to leads V2, 3, and 4. And the lateral wall, seen in V5 and V6, that can be supplied by the D3 branch or the LCX, which is an important anatomical variation to remember.
Finally, let's assemble all this information into a systematic, logical algorithm for localizing lesions along the length of the LAD. We're going to use the ECG patterns to basically walk back up the artery and find the point of occlusion.
So, the diagnostic question of where the lesion is located is answered by systematically checking for patterns of ST elevation across different lead groups. These groups correspond directly to the LAD's major branches. We just have to interrogate the ECG group by group. It's like detective work.
And the logic here is pretty straightforward. If you see ST elevation in the septal leads, V1 and V2, the lesion has to be proximal to the origin of the first septal perforator, S1. If you see elevation in the high lateral leads, I and AVL, the lesion is proximal to the first diagonal, D1. So if you see ST elevation across the septal, anterior, and high lateral leads, that signifies a very proximal LAD occlusion before any major branches have taken off. That means a massive amount of myocardium is at risk.
And now we conclude with the single most dangerous, most hemodynamically catastrophic ECG pattern of all, an occlusion of the left main coronary artery itself, the trunk where both the LAD and LCX come from. This is a true cardiological emergency.
So the pathonomic pattern you must never miss has 2 key findings. First, ST segment elevation isolated just to lead AVR. Lead AVR looks directly at the base of the heart, so its elevation represents a massive, basally directed injury vector. And second, this is accompanied by widespread diffuse ST depression across almost all the other leads. This combination screams subendocardial ischemia across nearly the entire left ventricle, and that's the sign of a left main occlusion or its equivalent.
So, we've just built a framework that transforms a simple, non-invasive tool into a powerful anatomical localization map. This level of analysis empowers you to anticipate hemodynamic consequences, to predict arrhythmias, and to truly understand the pathophysiology at play, not just react to a diagnosis. It really changes the ECG from a static picture into a dynamic guide.